Absolutely. Please go forward.
Great. I'll start with you, Commissioner Dorado.
Here.
Commissioner Chung.
Present.
And Commissioner Chow.
Present.
I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda is the approval of the minutes from January 11th, 2022.
I move to approve the minutes.
I second.
All right. And since there's three of you, I have to go through a roll call vote. Commissioner Chung?
Yes.
Commissioner Dorado?
Yes.
And Commissioner Chow?
Yes.
All right, thank you. The item passes. And I'm noting there's no one on the public comment line to ask for public comment. All right, I will share my screen for item 3, which is the tuberculosis program update. And my apologies to everyone around the spelling of the word tuberculosis. It's corrected on the version of the agenda on the website. Give me 30 seconds to pull this up.
Mark, I'm logging out and we'll log in again.
Thank you, Commissioner.
Thanks so much, Mark. Is this my cue to?
Secretary Morowitz, this is Susan Phillip. Would it be okay for me to say just a very brief remark?
Of course.
Before Dr. Graves begins?
Dr. Graves, please feel free to start the presentation. Just direct me around the next slide.
Thank you. I just very quickly wanted to say good afternoon, first of all, commissioners and Secretary Morowitz, and thank you very much for your time. And I want to express my appreciation to Dr. Graves and her team. This work is so important. I really appreciate the opportunity for her to share this with you as our SME in the department on TB. And TB elimination is a goal that we must continue to work towards. We are on the path. Her team is doing great work, and COVID has disrupted these plans as well as so many others around the department. But very glad to have her and her expert team continuing to show us the path forward to get there. So with that, I'll turn it over to Dr. Graves. Thank you.
Thanks so much, Mark, and members of the commission for this opportunity to share an update from the tuberculosis program. And thank you, Dr. Phillip, for that introduction. Mark, you can proceed to the next slide. So with an average of over 100 cases of active TB annually in the last decade in San Francisco, we are a high burden TB jurisdiction. And with the notable exception of 2020, TB incidence in San Francisco has been over 4 times the national incidence and well over twice the California incidence. You'll note the marked decrease in cases in 2020 that were reported and a moderate increase in 2021. The 2021 numbers are still preliminary until they've been certified by the state and reported by the CDC. Shelter in place certainly did have an impact across the board for many reportable conditions. And while masking and social distancing may have decreased the risk of new infections due to local transmission, this really only accounts for about 13% of TB cases, active TB cases in California. So it likely doesn't explain most of the drop in cases seen since 2020. In a study that was led by our TB clinic medical director, Janice Louie, we found that despite the decrease in reported cases, there was an increase in TB patients being hospitalized. And we suspect that a significant part of this decrease in reported cases is due to patients either not having access to care or not being diagnosed or delayed diagnosis due to the enormous focus of diagnosing and preventing the spread of COVID-19. The 2020, I mentioned that the 2021 incidence shown there is preliminary, but it's we're not back to our 2019 previous incidence. Next slide, please. There's definitely racial and ethnic disparity in active TB incidence. What we're looking at here is on the left axis, relative incidence compared with non-Hispanic white reference group, and then the absolute incidence over on the right-hand orange axis. So you can see that TB incidence among white residents is well below the overall US incidence at less than 1 per 100,000, but people in other race ethnicity categories are disproportionately affected. And for Asian Pacific Islanders living in SF, the risk of TB is more similar to the risk of TB among people living in Mexico than the US incidence. And in the following slides, I'll go through why we think that may be the case. You can advance. Some of this disparity can be explained by the exposure to tuberculosis in places outside the US where TB is highly endemic. Infection with TB can occur at any point in life when a person breathes in respiratory aerosols from another person infected with TB, and without treatment, 5 to 10% of these people will go on to develop active TB during their lifetime. About half of this risk occurs in the first 2 years after infection, making it really important to quickly identify people exposed to TB. But 80% of people diagnosed with active TB in San Francisco who were born outside the US have been living here for at least 5 years before their diagnosis. TB is preventable, and with early diagnosis during that latent stage when people have no symptoms and can't transmit TB, these are years of opportunity for intervention and prevention. You can advance. Also, for those infected with active TB who don't develop TB in the first couple years, the rest of the risk is spread out over the remaining years of their life and can be linked to the development of other medical conditions that weaken the body's defenses against TB, such as diabetes, which is present in 27% of our active TB patients, end-stage kidney disease, which is present in 5% of our active TB patients, or immune suppression due to cancer, HIV, or immune suppressive therapies, which is present in 11% of our cases in our most recent year that we have data for, which is 2020. These comorbid conditions tend to accumulate in older populations. I know we've heard a lot about this also in the context of COVID-19. And together with these comorbidities, it makes treating TB much more challenging in older patients. Even the shorter courses of treatment required for preventive therapy are harder to manage with respect to toxicities and drug-drug interactions among older patients. And when people arrive in older age, still harboring their latent TB infection, it presents a conundrum for providers who want to provide preventive treatment in their older patients. It becomes more difficult. The San Francisco TB Clinic, led by Medical Director Janice Louie, has become very expert at treating TB in older patients, incorporating cognitive assessments at intake and other geriatric best practices, and is looked to as a leader for treatment of older care and treatment of older TB patients by CDC designated regional centers of excellence. We work closely with health service providers to capacitate the treatment of medically complex latent TB infection, either in community clinics or in TB clinic by referral, to help support preventive services for older TB patients and older patients with LTBI. You can advance to the next slide. So based on data from CDPH, it's estimated that a small minority of TB cases are due to recent local transmission, and the vast bulk of TB cases are due to reactivation. But LTBI is not a rare condition. An estimated 6% of Californians have LTBI, but only an estimated 20% of them are aware of their diagnosis, and just over half of those have completed a preventive course of therapy. So ensuring access to information and appropriate care through the entirety of the LTBI care cascade, from initial risk assessment through diagnosis and preventive treatment completion, is the foundation of TB prevention work. You can go to the next slide. This map shows the annual incidence of active TB by zip code in San Francisco. The zip codes shown in yellow have a TB incidence that's similar to the rest of California. Those in light green reflect the San Francisco average, and those in the two darker shades of green show very high TB incidence. That's 4 to 7 times the California incidence, 7 to 15 times the US incidence. So we're looking at real disparities by location as well. Highly focused TB prevention efforts include evaluation and treatment of contacts to active TB cases, with an average of over 500 contacts to TB cases evaluated each year. For those contacts to smear positive cases who were found to have TB infection, treatment was initiated for about 76% of those and completed by 89% of those in 2019. These contacts are closely linked and also cluster in the most highly affected areas that you're seeing there in your map. In addition to contacts who've been exposed to TB, prevention efforts are also focused in TB clinic on arriving immigrants who have been referred because of chest imaging that's concerning for TB, with an average of over 200 referrals each year in the 5 years leading up to 2020. There had been a significant waning of arrivals during 2020, which started to pick up again in the latter half of 2021. In 2020 and 2021, the larger in-person events of prior years that we had used to promote TB field outreach and testing have shifted to focus on COVID-related services, and are now, with the Linkage Center in the Tenderloin and other integrated efforts expanding to encompass outreach related to other communicable diseases and other linkage to care services in general as an integrated effort. You can advance the next slide. So birth outside the US in a country with high TB incidence is the most common risk factor for San Franciscans with TB. When we layer this risk factor together with other social determinants of health that affect access to care, such as poverty, neighborhoods emerge in which we can focus our prevention efforts. Partnerships with community-based organizations and clinics working in these neighborhoods to promote access and linkage to care expanded during the COVID response. And our program is working to build on these successes of these partnerships and pilot some outreach in SRO buildings where crowding and shared airspace put residents at higher risk for respiratory illness. We're prioritizing buildings with high numbers of positive TB tests or recent TB test conversions that suggest possible recent TB infection among residents. And we're hoping to roll these into the general DPH linkage to care efforts in these neighborhoods. And just to note, the map on the right is from the Berkeley Interdisciplinary Migration Institute. This is not DPH data, but it's sourced from this institute's study on clinics serving these populations, as well as legal aid services. You can advance the next slide. So our approach to TB prevention goes beyond the work that we do here in TB Clinic to involve health providers and community partners, as well as congregate care and residential care settings, health systems, and of course, our program that's associated with our clinic. And we have been, the TB program has done a lot of support for the COVID response. And while that resulted in a smaller staff to perform our core services in the last 2 years, it's also helped us build our expertise and leverage these partnerships that we've developed with our partners in COVID prevention, treatment, and mitigation. You can advance to the next slide. I just wanted to thank the EPI support for a TB program, Laura Romo, our program manager, who's also an epidemiologist, as well as Kathleen Shing and Jose Gonzalez, the epidemiologists who provide our program data and the maps and graphs that you saw there. Do you have any questions?
Commissioners, there are a few people on the line. I'm not sure if they're staff here to support or not. I don't recognize the name, so I'll go to them first. Folks on the line, if you'd like to make public comment on this item, which is the TB update, item 3, please press *3 to raise your hand so we can acknowledge you. *3. All right, I don't see any hands, Commissioners. It's all you. Dr. Chow.
Yes, and thank you. And I want to thank Dr. Graves and for this very explicit and very thorough evaluation of the work that you're all doing. And I'm glad you pointed out on the active TB cases. At first, I thought, oh, we're getting there, and then I realized that you just pointed out that some of the lowering is certainly, you know, an influence of COVID, and so that represents continue to be a basic question about what we should be doing more, if possible, to try to get closer to either the California or San Francisco rates. And perhaps from what you were saying about Mexico, it might be that the California rates are more appropriate to try to measure by. But I'm wondering first that as I looked at these, and I'll give you my background, I had a lot of interest in tuberculosis and its treatment in our community for many years. And when we had the health department to have joined the health department, at that time we did have a direct patient clinic right in Chinatown. And so as I wrote, one of my questions was, is that still a viable option? Is that a way to help capture, especially as you pointed out, that it's become more complex with older people and the difficulty of assuring that the preventive, because most of these are latent TB that you're talking about, the active TB obviously are, you know, seen, treated. We've had patients at the 2 or 3 hospitals that I went to and diagnosed, and you know, they got their treatment, they were able to get out after the infectious period was over. And then they were continued, many of them were younger, and they continued on their own, being monitored by the city and reports then back to the city. So it seemed to me that for these, that doesn't just extend to 2012. I think it would go back as far as I'm concerned, back to almost 30 years ago. This was always the case. We had high levels, and our ability to give you more resources, I think, were a real problem. And so while I could, you know, go into some of the detail, I guess one of the questions that I would wonder in today's emphasis on equity, and also the need to take a very important problem that actually has public health implications, and for which we've been told that once the government have withdrawn resources, maybe a dozen years ago or more, that we had to drop the clinic in Chinatown. So I'm not advocating for a clinic in Chinatown or anywhere else. And possibly from what you were showing, there should be something in the Tenderloin in order to help achieve this. But I think we have not heard whether or not with all this data displayed, and I could argue that actually we need to disaggregate the Asian and Pacific Islanders, particularly in this case, and possibly even look at the Mexican American population from what you had just said. This is a perfect place to do some of the disaggregation, and I think a very right time to look at resources we need. We're putting a lot of resources into many things that we weren't able to do in the past, and I would hate to see that for all the years that we've known that, this is one of the failures, you might say, in San Francisco public health, that we have an opportunity to assist this population, which we have not done for these years. So that's kind of my comment about where I'm hoping that if we can understand what resources else we need for you to successfully drive the numbers down, I think it's just as important as trying to reduce pedestrian injuries. We should reduce the latent TB that we have in the city. As you have demonstrated, this is really important. And I'm not sure that we understand the types of resources that you might need in order to be able to accomplish that goal.
Thank you, Commissioner Chow. I didn't come prepared with budget asks. Those were submitted earlier, and I'm happy to review those or send them on. But in terms of our approach, our general approach, we provide directly observed therapy here in our centralized clinic in San Francisco General Hospital. And I think the DOT clinic you're referring to is the one that previously was in the Chinatown Public Health Center. Chinatown Public Health Center doesn't have a DOT clinic specifically, but they have an integrated nurse case managed program for management of patients with LTBI that's protocolized through their nursing section. And another clinic that does a lot of service in Chinatown, NEMS, recently got a huge grant from the CDC to focus on TB care cascade, LTBI care cascade improvement projects. And we're partnering closely with them on that. They're also partnering with us on the SRO outreach that we are working on piloting as well. But I think when you look at the scope of the problem of LTBI in San Francisco and TB prevention in San Francisco, it's really clear that linkage to primary care and having this testing and treatment initiation and treatment completion tracked through in a primary care setting with linkage to primary care is the way that we're going to be able to scale this up. And so we're supporting that certainly within the health network, but especially with community partners that serve the populations in the neighborhoods that you saw highlighted on the screen. But absolutely, we did make some requests about outreach in our budget, and I can submit those specifics to you after this presentation if it's requested.
Well, I certainly thank you for not only the previous information that you have provided, but this other information in at least the Chinatown area, and I'm really congratulating them to be able to get the grant. That's really helpful, and that there is some DOT still going on in the Chinatown clinic. Because I know at one time everybody had to be sent down to General. Not that you weren't great, but that was really kind of a barrier, right, to a lot of people. So I would be encouraged from that in the fact that in one community it looks like there is an initiative going on, and I think that the idea of linking it to primary care is very good. I'm just wondering in the community, because a good bulk of the community is being taken care of aside from NEMS and the public health by the other sector, the private sector, and they have medical groups that take care of probably a very high percentage of the Medicare population under MA plans. I'm not aware that there have been outreach in regards to the ability to handle tuberculosis. And even though your chart shows that there are a fair number of community linkages and all, whether that community linkage is as robust as it could be in order to, and that of course means bringing resources too, right? We can't just ask people to do something and then say, oh, and on your own, by the way, do the education, set up the seminars or whatever it is, because it sounds like you got a great program going that aside from resources, which I'll be very happy to look at just to understand, we obviously don't get involved with the administration, but it would be good to know how you have all been approaching this. But to be able to then work organized, you've got 2 big blocks already, the Public Health Department and NIMS. And I think in that community, and that extends into the Richmond and Sunset, particularly because we don't have a public health clinic really in those areas. The private sector is really taking care of these people by way of 2 or 3 large groups. And not saying, that, well, no, yeah, I think that if we worked with them, that would be part of the primary care linkage. So it would be not only through our public health department, public linkages, primary care linkages, but it would be a very important face where so many people are getting their care from the 200 or 300 primary care doctors that are still in this sector. So that also doesn't speak to the fact that I think things like Hill and Brown Tolan could then direct their resources towards that. And that might just take, a more community approach towards this, because again, they would reach many of these same primary doctors, but that would be a way in which I know we did this when we were doing the hepatitis programs and all. We got all these people on board, and it became a large community program. And so it just seems to me tuberculosis has been here even longer than the awareness and the ability to impact Hep B chronically, and that this might be the right time to try to do that. But so I don't want to, belabor the point, but I think it would be good, Madam Chair, if we were to get a report back in about 6 months as to get better data now that we understand some of this dip is from COVID, and understand how this approach from the department with their 1, 2, 3, 4, 5 approaches is really working. And I think we need to pay more attention to this. We've been distracted, and rightly so, by many problems, including critical, financial issues for many years, so that we didn't really push this, or I didn't push it much more. But I think that this might be the right time with this type of program that you have going on for us to follow it a little more closely. So thank you.
Commissioner Gerardo.
Thank you. And I would request then, based on Commissioner Chow, if we could request in 6 months to have an update on the items of approach to TB prevention with further data. Am I correct, Commissioner Chow?
Yes, sorry, I had to get off of. Yes, I think that they have a good plan laid out. I still would like to see that they also look at the disaggregated data, which can take
Okay.
a number of people, and coming along with that and seeing how they might be then outreaching some of the other components of the communities would be really helpful.
Okay, thank you. And I have a couple of questions as well, and I will apologize if in fact you covered these. I had major technical issues and had to switch to a second laptop. So, but one of my questions was, is there a focused outreach for those over age 65 that has a positive wellness focus, since many people could feel negatively anxious about TB?
So we don't have a direct community outreach directly from TB Clinic to older populations. We've focused our outreach for older populations through organizations that serve as part of primary care or residential care. We've conducted trainings and worked closely on referrals regarding cases of complex LTBI with providers such as OnLock, as well as primary care providers that serve a broad spectrum of patients, but including older patients.
Okay. I understand. And is there a known reason for the spike in TB cases from 2020 to 2021? I know you had mentioned COVID, but was there any other specific reason or that you were aware of in your data?
When you say the spike, do you mean the increase between the nadir in 2020 to the increase this year of 8.4 per 100,000?
Yeah.
So in our data, what we've seen is a higher proportion of cases presenting as very ill. And there's a little more background on that in the paper that is shared from Dr. Louie. But essentially, I'm concerned that the 6.7 per 100,000 is really, while those are all of the reported cases, that there may have been some less seriously ill TB cases that may not have been diagnosed and therefore not reported. During that year, our population had serious challenges with access to care, particularly during the initial months of shelter in place, because a lot of our active TB patients are older adults with other social determinants of health, poverty, other challenges with linking to, for example, telehealth services, which replaced a lot of the in-person services during those months, and honestly still a lot of healthcare is being conducted via telehealth, and there continues to be challenges with access to care. So I think the 6.7 per 100,000 is actually, unfortunately, not representing a dramatic improvement in the number of actual TB cases in San Francisco, and that 8.4 is hopefully reflecting a more accurate, a more complete picture of TB in San Francisco. So I think with improved access to care and improved access to diagnosis and care for TB patients, we're seeing a return to better ability for patients to get diagnosed, access care, and then be reported and be case managed by our program as well.
Okay, so it's basically during COVID, there were significant access issues.
I think so. There were fewer.
As well as diagnosis. I mean, I would assume you can't do that by telehealth, you know?
No, it requires an X-ray, among other things.
Exactly. That's what I mean, you know, nor can, you have a TB test, either X-ray or whatever, telehealth wise. So it was really the access because of COVID.
I'm concerned about that. I'm also concerned about, because of the syndromic overlap, both our respiratory illnesses, both have a component of cough, that in particular, these patients may have been the ones that were told, oh, come to clinic on another day when you don't have a cough, and may have had challenges accessing care because of the syndromic overlap. And when providers are thinking about how to go about working up a patient, and COVID is front of mind, of course, that's going to get worked up. And then you hope that with our outreach efforts and education efforts, we can make sure that they're considering these other diagnoses, which active TB is clearly more rare than COVID. So appropriate to look for both in the right clinical context.
So there's catch up.
Yes, I think that's what's reflected there.
Okay. Thank you very much.
Any other questions, commissioners? All right. Thank you very much, Dr. Graves.
Thank you for the opportunity to speak.
Mark, could we just ask, because I was just again reviewing Dr. Louis' paper on the COVID relationship, and I was looking at the chart and trying to understand. I mean, I understand the premise being that there is a problem, just as Dr. Graves had talked about, but in the graphs, I wasn't quite sure what I was supposed to actually draw from the graph.
Are you looking at the graph from Dr. Louis' article
Yes,
with the
correct.
different color bars?
Yeah, and
Um,
it's really great that you, well, the copy we have isn't in color bars, and maybe
Oh,
that's the
sorry,
best.
they're black and hatch marks.
Yeah,
Yes.
so I'm just trying to decide what I should have learned from it. I understood from what you just said that this is sort of a conclusion, and it's wonderful that it was published. So am I missing something else?
So what you can see if you look at I'm not looking at the graph myself right now, but you can see there's an arrow down that indicates when shelter in place started. And what you see there is that the white, I think they're the white bars, the tallest ones, which are reported cases, total reported cases, go down significantly during that time. But the black, I believe they're the black bars, which show hospitalizations. They're actually kind of steady or maybe increased there,
I
showing that people are presenting at a later, more advanced disease stage. They're not getting diagnosed out of the hospital. They're getting so sick that they go to the hospital and getting diagnosed there. I think is, you know, what we think these trends are showing. There's also a table down there looking at, in the months leading up to shelter in place. And then if you look at the months after shelter in place, the proportion of patients requiring TB patients requiring hospitalization was greater in the post shelter in place timeframe.
Okay,
So-
well, I thank you for the explanation. Obviously, I should have been able to see that from understanding the bars, but they kind of came out small, and I really appreciate your help in reading this. And once again, want to really be grateful that we've talked about all the different work and papers that do come out of the department, and it's really nice to see one and really understand the impact our department is making, on the national medical scene. So thank you.
Thank you.
All right, thanks again, Dr. Gray. So we're going to head on to the next item, item 4, which is the Behavioral Health Services Children, Youth, and Family Systems of Care update on closure of Juvenile Hall. I'm going to share my screen to get the presentation.
Thank you. Oh, great. Mr. Moritz, are you going to share it for us?
Oh,
Thank you
yeah. I'm sorry. I thought that, yes. Is that okay?
That's great. Yes, that's great. Thank you so much. Hi, everyone. Thank you, commissioners, for inviting us, and Mr. Morowitz for supporting us in our process getting here. My name is Farah, Farah for short. I'm the director of the Children, Youth, Family System of Care here in Behavioral Health and a child psychologist by training. And I've got Mona Tassini with me here, who's going to be presenting with me. And she is the director of the clinic inside of Juvenile Hall that DPH runs, as well as a program linked to probation that helps kids in the community. Just to give a little context, we were asked to come here today to talk about updates regarding the Juvenile Hall closure. And so we also did submit an 88-page report, and we're going to be presenting some of the highlights from that consultant report regarding the closure that really summarizes the discussions that took place and the recommendations that are being made from that process. We're going to try to really focus on areas that do or may impact DPH specifically, because this is a very large rollout and much of the work has to do with systems outside of DPH. But also just know that this work is just beginning. We may not be able to answer a lot of questions, even for aspects that relate to DPH, because so much of it has not yet been determined. They just held their first Board of Supervisors hearing on Friday at the Youth and Young Adult Committee. That was the first meeting, and the consultants that created the report, as well as Dr. Cheryl Davis at the Human Rights Commission, presented on the report, and Chief Miller, the head of Juvenile Probation Department, was called to the hearing and really spoke to the laws and regulations that govern juvenile justice and laid out the various departments and stakeholders that need to be engaged in planning and implementing these various recommendations. So Supervisor Ronan and Supervisor Walton had acknowledged that the work is just beginning. And really, from where we stand in DPH, there really is not a clear idea on what, how, and when the recommendations will be implemented. So we'll do our best to just present sort of the facts as we know it and the implications and go from there. And we also did receive some of the questions ahead of time. Thank you so much for providing those. And we are working to integrate that into our presentation. And of course, hopefully can get to any other questions at the end. Next slide.
Sorry, give me a second. I don't know what happened. Oh, there we go. Okay.
No problem. So we won't spend too much time on this background. We did present on this last time, but just as a reminder for the context of the legislation, the ordinance to close juvenile hall passed by the Board of Supervisors in June of 2019, and it amends the administrative code to require juvenile hall to close by December 31st, 2021. So the first sneak peek is that the hall did not close December 31st, 2021. It's still up and it's running as of right now. The process, however, the legislation also indicates expanding community-based alternatives to detention, as well as replacing the current juvenile hall with a rehabilitative non-institutional place or places of detention that should be approved by the court, as well as the Board of Supervisors and the Board of State and Community Corrections. The process ensued the closed juvenile hall work group process. It was a 15-member panel appointed by the Board of Supervisors to develop a plan for the closure by June 1st, 2021. It was spearheaded by the Human Rights Commission and led by consultants, the Byrne Institute and the National Institute for Criminal Justice Reform. Next slide. So the report from the consultants, there was a 6-month delay in the submission of the report. You know, people had to adapt to the COVID pandemic and things slowed down. But the report was submitted on November 29th, 2021, and you all should have received a copy. It's an 88-page report, and it mostly focuses on systems outside of DPH. For example, policing and arrest, probation, court processes. The report summarizes a lot of the discussions and recommendations in the different area of focus you see on this slide. So for example, there's a big focus on, and there's a star next to the implications for DPH programming, which I'll get to and sort of focus on more intensely in the next slide. But some examples of things that are highlighted in the report are really a focus on diversion. So for example, it stipulates that San Francisco should aim to divert at least 80% of youth at the point of law enforcement contact. There's also a specific proposal here for the community-based intake and connection hub or well-being center that will serve as the direct referral pathway for any youth who comes into contact with the police. And I can speak more to this on the next slide, as it also relates to the reimagining well-being alternatives to detention. But some of the other areas of focus in the report outside of the DPH system is working with SFPD to reform booking practices and incorporate adolescent development, policies to avoid issuing warrants to the greatest extent possible, limiting time on probation, expediting or having same-day detention hearings, expanding detention alternatives sooner and more often, and eliminating or limiting the role of the probation department in supervising youth on home detention, and then ensuring unaccompanied minors with contact with the justice system have access to appropriate representation by specialized attorneys. The other areas I'll talk more intensely about on the next slide is really around reducing the reliance on detention of out-of-home placements, the non-institutional place of detention that will replace our current juvenile hall other community alternatives, and then reimagining well-being alternatives to detention. Next slide. Okay, so there's a lot to unpack on this slide. The reason why we got called here today was an update on the juvenile hall closure. I'll say that that's a very small piece of this 88-page report, because really the focus is on diverting youth and expanding community alternatives so kids don't even end up in the hall or in the new place of non-institutional detention. However, they do outline some recommendations related to what they're naming the rehabilitative non-institutional place of detention. Most notably, the recommendations include separating out whether it's different cottages on the same campus or different facilities across San Francisco, 3 facilities that are broken down by population. So they have a binary concept of gender and separating out girls and boys. And they recommend a separate home for girls, no more than 5 beds, at any point in sort of the justice system. So whether they're pre-adjudicated, post-adjudicated, or pre-placement, there's 1 home for girls that are no more than 5 beds. The other 2 homes would be for boys, separated out pre-adjudicated, 8 to 12 beds, and then post-adjudicated and pre-placement, 8 to 12 beds. They also speak to, and the facility should be like a home-like residential home, family-centered, non-institutional type setting. So they describe some of what that those characteristics should be, and they propose a couple sites that they have explored in the report. They also speak to staffing and specifically note a 1-to-5 ratio of staff to youth during waking hours. And they also note that there should be shared leadership between community-based organizations and Juvenile Probation Department in the design and the operation of the 24-hour centers. So what's important to note here is the implications for this are, we do have, as Mona is gonna talk more about, we've talked in the past and she'll talk more in her presentation, we do have a DPH clinic inside Juvenile Hall currently that provides behavioral health, medical, nursing services, and we are bound, the juvenile, whatever new setting gets established is bound by Title 15 standards, regulations for medical and mental health services in juvenile facilities. So this 1-to-5 staff ratio needs to be examined within the context of what Title 15 requires. And it's unclear DPH's role in delivering these Title 15 services. If the community, the joint community CBO, JPD design and operation includes these Title 15 services or really other augmented psychosocial programming within the hall or the new place of detention. So that's the piece around the sort of new proposals for non-institutional places of detention. The other areas from the report that overlap with some DPH implications really have to do with alternative to detention and expanding community support. So the next one is reducing reliance on detention for out-of-home placements. And the piece to this that really overlaps with DPH is increasing comprehensive supports to families and trying to reduce congregate care placements. And so there's a lot of aspects to this, but what's important to note is we do have, we are working with Juvenile Probation Department and Child Welfare in implementing the Federal Family First Prevention Services Act. Those departments, JPD and Child Welfare, will be receiving funding, federal funding, to support the implementation of specific prevention services for families. And DPH is a partner in this. So we're working with them on the plan. The work is just getting started and it's being guided and a little bit prescribed by the state. So we all share a goal of really building out robust preventative and family-focused services. While we already do have a continuum of care for families that expand prevention and health promotion all the way to intensive services, as well as mental health services within residential settings, we hope this new federal funding that's focused on preventing out-of-home placements will help fill gaps where Medi-Cal does not reimburse for services and expand the capacity of providers to serve more families. because capacity is an issue in our system just across the board, which I can speak more to. A lot of the other recommendations in this section of the report discuss is really outside of our purview. For example, there's a focus on the Juvenile Probation Department process for case planning, for engaging families, family finding services to support placements with kin and extended family, JPD investing in foster care family homes and providing that provide intensive services as alternatives to congregate care placements like residential, short-term residential treatment programs, STRTPs. There was a specific focus in the report on improving protocols for youth that may AWOL from out-of-home placements. And I know the commissioners had a question on the process for kids that AWOL from these settings and the percentage of San Francisco JPD youth that have AWOL. So we did ask our JPD partners who reported that on average in 2021, 16% of our home placement youth were AWOL, and in January 2022, 9% were AWOL, 3 out of 34. The general policies in some of these settings is like the short-term residential treatment programs is to follow the kids and try the staff, if they see that a kid is AWOLing, to try to follow them and convince them to come back to the placement. But it's also protocol to alert the probation officer if they can't convince the youth to come back, and they do have to file an AWOL report with the police. And I know that this report that was published is excuse me, really recommending reviewing the process for kids that might AWOL. So their departure doesn't result in a warrant and another arrest and then being detained in the hall just to await another placement. There was also a question from the commissioners on if community-based alternatives to detentions have been identified and if wraparound is part of this. It is important to note that the Juvenile Probation Department has already taken steps to secure alternative placements. So they did secure some intensive treatment foster care beds through one of the community-based programs, Alternative Family Services, as an alternative placement for youth. WRAP is also a service that's available to youth on probation in the community. And the state does require wraparound services in the aftercare plan for any youth discharging from STRTP placements. Sorry, I feel like I got a tickle in my throat. Apologies. The next item is to develop a well-being committee, but this is part of the larger goal of reimagining well-being alternatives to detention. I believe DPH was specifically named as a partner in this well-being committee, and that's why it's specified on the slide, and it's really focused on establishing restorative justice practices outside of the formal court structure. However, I'm gonna back up here and speak to the larger Hub Well-Being Center concept, as that was a question of the commissioners. But please know that much of this is likely outside of DPH's purview, but I will summarize some of the key points from the report. So as part of the diversion goal that this reform effort is moving forward, the report recommends implementation of a community-based intake and connection hub and well-being center that's available citywide to schools, parents, and service providers, and that is not connected to any law enforcement entities such as the police or the probation department. The site will serve as a critical diversion pathway that does not rely on arrests, but instead holistic approaches that focus on health and well-being and centers youth and family. When youth do require intervention and support, the center can serve as a streamlined point of entry and support connection to resources such as housing, healthcare, food, childcare, behavioral health, transportation, employment, youth development, enrichment, and education. In the report, they speak to infrastructure that already exists for this through the Department of Children, Youth, and Families, and 6 funded agencies that DCYF funds throughout the city. They're really looking at those agencies to figure out if more flexible funding could be included into those and restructuring those agencies to sort of respond to the needs of families. But the report also does specify that this hub and well-being center would serve as the direct referral pathway for any youth that does come in contact with the police. And for those youth, they're proposing the following sort of pathway. And there's a really nice visual of this in the report somewhere. But they speak to the first contact being a well-being advocate. That's the first contact, and sort of serves as a system navigator to help support families through the process. They ensue a well-being assessment to assess for appropriate services and develop a roadmap to well-being. And then the well-being committee, which DPH was named as being part of the committee, would include a collaborative process to address the needs of the young person accused of doing harm and the person harmed that engages in restorative practices outside of the formal court structure. So again, this hub is beyond DPH, but DPH would have a critical role to play in terms of linking youth to behavioral health services based on needs that arise from the well-being assessment and from what it sounds like this larger well-being committee. I'm going to go ahead and move on to the next bucket, which is what they coined structural changes for behavioral and mental health. And this basically really just speaks to more flexible funding, right? In our department, we really rely on federal funding, EPSDT, to provide specialty mental health services. And with that funding comes stipulation for specific types of assessments and protocols or eligibility. So they're really trying to, I think, loosen restrictions and diversify, like, rely more on general funds and DCYF funding and change program requirements to services to extend sort of the beyond the terms of probation. So just as a reminder, currently when youth are in juvenile hall, you'll hear more about this from Mona, but they do have access to behavioral health services 10 hours, 7 days a week. All youth meet with a behavioral health clinician for comprehensive psychosocial assessment upon admission, and behavioral health services are provided to youth in custody, including individual, group therapy, crisis intervention, psychiatry, and care coordination. And these are all funded through general funds, given gaps in Medi-Cal coverage to kids that are in custody. Youth are also linked to mental health services in the community, and these community-based services can continue to provide services regardless of the youth's probation status. There's only one intensive service that requires youth to be on probation, which is wraparound, but we also have something that we like to call WRAP Light, ICC-HBS, that's available for all youth regardless of status. And all DPH outpatient and other intensive services providers can provide services regardless of probation terms. We also get blended funds from DCYF work orders to put into the contracts of these providers to allow them flex funding to support engagement of youth, like in the courts and other areas where Medi-Cal doesn't reimburse. And the final note around this, in terms of alignment for this goal, is there are larger behavioral health reform efforts at the state. Cali, most notably, is changing the definition of medical necessity and basically who can access our services. And there is justice-involved youth is one of that mechanism. And so there are going to be renewed criteria in terms of the documentation that's needed, no wrong door policies. With that said, it's still federal EPSDT funding, and there still are requirements tied to that. So the notion of CANS assessments and other sort of tools and measures, will not go away for kids that need to access our services. The final point I'll say that was something mentioned in the report, but not a formal recommendation, is the notion that to reduce the silos between city departments that folks feel are present and increase accountability, there should be one department responsible for youth and family well-being for justice-involved youth. And I will just say that this parallels, not directly overlaps, but parallels some of the recommendations from the Mayor's COVID Recovery Task Force for Children and Youth, which speaks to a similar model of sort of the child serving departments coming under sort of one leadership and head. But within the context of this juvenile justice reform, they specifically speak to the Juvenile Probation Department, Department of Children, Youth, and Families, and then DPH, which would be us, the Children, Youth, Family System of Care, being under this umbrella. So in summary, until we know more about what, when, and how the recommendations will move forward, and who is sort of responsible and accountable, we continue to just focus on delivering the best possible care to youth that are in custody, continue to fund our community-based organizations that support youth in the community with specialty mental health services. And we're gonna, I'm gonna pass the baton to Mona so she can talk about the current snapshot of youth in juvenile hall, our staffing and services, and new legislation we're implementing for our youth.
Great, thank you, Farah. So over the past 5 years, we have seen a steady decline in the average daily population at juvenile hall. It remained stable between 2017 through 2018 with an average daily population of 45 in 2017 and 47 in 2018. It has significantly decreased over the last 3 years with an average daily population of 30 in 2019 and an average daily population of 17 in 2020. This significant decrease is really due to COVID, which led to historic declines in local, state, and national crime and arrest rates really across the entire nation. This past year, in 2021, the average daily population declined even further with an average daily population of 14. Again, a lot of this is contributed to COVID and also some of the juvenile justice reform efforts that are happening here in San Francisco. This past year, JPD implemented new policies that required the chief to sign off on any detentions for probation violations and really just continuing to divert non-serious offenses and look at alternatives to detaining youth. We did see some different trends in terms of our population. We, this past year, saw more youth that are 18 and older. This is related to Governor Newsom signing SB 823. I'll talk more about this later on. But this really this ended up closing the Department of Juvenile Justice across the state. So we're seeing more of these youth in custody, and what shifted was some of the licensing. Historically, youth could not be in custody past the age of 18. So most youth would have to be transferred to an adult facility before their 19th birthday. And this shifted in terms of the licensing because of this legislation. We can now house youth up till the day before their 25th birthday. So this shifted kind of who we're seeing. We also saw a lot of youth with, longer detentions or being actually committed by the judges to juvenile hall. Again, a lot of this is contributed to community care reform and, really trying to have less reliance on out-of-home placements, which has also resulted in a lot of us losing a lot of placement options for youth. We historically were able to send youth out of state. That's no longer available to us. And a lot of our placements here in California have unfortunately closed or just don't have the capacity to serve our youth the way they once did. Next slide, please. So this table really shows just our current staffing model. As we reported the last time we met, with the declining census and uncertainty about the future of juvenile hall, we have not been filling vacant positions above and beyond what is necessary to really ensure, good quality clinical care and to meet Title 15 regulations around medical and mental health services within a juvenile detention facility. So our current staffing, we're at about 14.8 FTEs. About 10 years ago, when we had an average daily population that was, 100 plus, we were at about 33 FTEs. So it's a pretty significant reduction. As we've made these shifts, we've really done it in collaboration with our stakeholders, our partners in juvenile probation, and some of the other system involved partners. I mean, our goal is to really ensure that there's no impact to the care that youth are receiving while they're in custody. And the good part about this is our staffing model is still above the minimum requirements of Title 15, and we still continue to provide more services to youth in comparison to our other neighboring Bay Area juvenile halls. We have moved some of our vacant positions from SPY to other children, youth, and family clinics who have needed additional staffing support. And really, this is with the goal in mind of supporting our community programming with the goal of, preventing youth and families from being involved in the juvenile justice system. So as things continue to shift and there are just, possibly more declines in our census and changes, we will continue to explore our staffing models and figure out, what makes sense in terms of moving forward. I know there was a specific question around just continuity of care and continued access to services when youth are released and, the case management piece. This is definitely a huge need and a goal of ours. Especially with some of the reform efforts, we see kids coming in and out a little bit faster than they did before. So we often don't have as much time to really align services for youth and families when they leave. But we do have Aim Higher, which is our program that really focuses on the behavioral health piece, assessing youth and linking them to behavioral health services upon release from custody. In terms of ongoing medical care, we definitely make sure families are linked up with knowing how to access services in the community. And if they had any kind of subspecialty appointments set up, ortho, neurology, anything like that that was set up while they were in custody, we will obviously inform the families, follow up after, reminding them of the visit. And then we also have a public health nurse that works with JPD involved youth while they're in placement and in the community here in San Francisco. And so we work very collaboratively with them so they can help connect our families. Next slide, please. So yeah, it has been quite a couple years for us with everything going on in terms of juvenile justice reform and really COVID. And so, our focus really remains on being committed to providing high quality clinical services to our youth and really just kind of adapting with the many changes that come with juvenile justice reform and everything else that's happening. We are supporting a lot of new legislation. The Federal First Prevention Services Act, the Quality Improvement Mandate. So this is federal legislation that enhances support services for families to help children remain at home, reduce the use of unnecessary congregate care placements by increasing options for prevention services, and increase oversight and requirements for congregate care placements. As Farah mentioned, this directly impacts JPD and HSA involved youth. One part of this legislation is that if a youth is recommended for an out-of-home placement, they must have an assessment by a qualified individual, a mental health provider, that would determine if their needs can be met in a family-based setting or why an out-of-home placement would be the appropriate placement. SPY is currently completing these assessments for all JPD involved youth that are being recommended for out-of-home placement. The other piece of legislation that is really impacting us is, and again, I spoke to this briefly, but Governor Newsom signing SB 823, which shifted responsibility and funding for custody care and supervision of youth who would have been eligible for California Division of Juvenile Justice, DJJ, from the state to local counties. So once this bill was signed, no further commitments were made to DJJ as of July 1st, 2021. And so this essentially closed all of California's youth prisons and shifted again that focus to the counties to determine a plan for these youth. JPD has convened a subcommittee to develop a plan for these youth, and DPH has been a part of that committee, as well as other system partners, the school department, other community folks. So they do have a committee for that, and we have submitted a plan. However, that process takes a little bit longer than when it's actually closed down, and so this has impacted us in the sense that when as they were releasing youth that had been committed back to DJJ, sending them back to their counties. We were getting those youth and supporting them and preparing to parole back out to the community here in San Francisco. And then we currently have 3 young adults that have also been committed to what they're calling the Secure Track program and will remain in custody with us until the age of 25. And so this, requires a tremendous amount of support from our team in terms of really identifying, long-term treatment goals, addressing medical needs, and just a significant amount of care coordination with JPD, any outside providers, the youth's families. So this has been a really big shift for us. And much like most of the world, a lot of our time has been devoted to COVID response. We've, really taken the lead for JPD and some of the system stakeholders like the courts, and really just being a consultant, developing procedures for the institution in line with CDC recommendations. So this has included, getting testing on site, changing testing protocols, quarantine protocols for any new youth in custody, and just really being a consultant to all the system partners that are, involved in the juvenile justice world, and how to kind of navigate all of this. And with that, I just really want to take this opportunity to really acknowledge our team. It's been a challenging time navigating really the uncertainty about the impending closure, kind of figuring out what, our focus is, and kind of, are we opening, are we closing, and, but really staying committed to kind of the goals and mission, particularly as frontline workers and during the pandemic. It's been at different points throughout the last almost going on 3 years. Visiting has been ended because of COVID and like during different surges. And so this has really, made it difficult for our youth not having access to outside providers, to teachers, to their families. And so really their only kind of support has often been the medical and behavioral health staff from SPY. And so they've just needed a lot more support, and definitely increased anxiety, being, even more isolated from their connections. So just a lot of really incredible work by this team, and just really going above and beyond. I can think of one story just right when we had this last surge with Omicron. It was right around the holidays. One of our behavioral health clinicians had worked to get some gifts for one of our young ladies who'd been in custody for an extended period of time for her son, her infant son. And there was a visit planned for him to come visit her and, be able to get these gifts from his mother. And unfortunately, that was canceled due to this surge. And she was able to get out into the community and bring these gifts to him, and schedule, a video visit for her to be able to interact with her son while he opened these gifts. And so it's just been really incredible to see the way the team has really stepped up, through COVID, through all of the, uncertainty around juvenile justice reform and the closure. And so just really wanted to take that opportunity and acknowledge our team and all the incredible work they're doing. So I'm going to kick it back to Farah, and we're happy to take any questions you guys may have.
Thank you so much, Mona.
And commissioners,
And that's, yeah.
Is it okay if I go to public comment, Farah? Okay, great.
Yeah.
Folks on the line, if you'd like to make comment on this item, which is the Behavioral Health Services Children and Youth and Family Systems of Care Update on Closure of Juvenile Hall, which is item 4, please press *3 now. *3. All right, commissioners, looks like Commissioner Gerardo has a question. There is no public comment.
Great. I'm surprised that there's not any public comment, because I know this is quite a community issue, to say the least. But I really appreciate your report. And thank you for answering most of my questions that I had put forth. But within what DPH is providing at Juvenile Hall with the 14 staff members, in going forward, this is going to be hopefully integrated into the community-based out-of-home placement or my concern, since I guess I've had just a personal relationship with a number of youth who had been in juvenile hall on a professional basis. I'm a child adolescent psychologist. And so my biggest concern is what you had addressed as a challenge is the case management, that is going to be a key part. Many of the youth that I have dealt with really have not until juvenile hall received adequate medical care, dental, or behavioral health. And as we all know in the statistics, at least many of them are assessed by the SFUSD, and they're 80% in the data have learning disabilities, and they're I know one of mine was reading level at age 16 was second grade. So I guess my real concern in splitting up the hub of the DPH services without any kind of case management, I have a significant concern that I hope you will just push forward to the Board of Soups, but also it's the availability. I mean, yes, access to care in the community is absolutely, I'm all for it. But there in behavioral health, there's like no slots, very few slots in the community. So what is in theory is excellent, but then the practical application, I guess I'm really concerned with your push and input going forward. So as things eventually shut down, it's not kicked back to say you should have, could have, would have, these kids are now homeless because they can't, access services because there aren't any. I guess, so that's, not only a statement, but, a question. And I'm hearing that was one of your concerns in kind of push. Am I on the right track here?
Yes, absolutely, Commissioner. There's still a lot of unknowns. A lot of the first unknown is, what is happening to the SPY staff. I don't know if they're coming to other clinics to sort of expand community alternatives, or if they do have a role in continuing the Title 15 medical and behavioral health services in the new place of detention, because there will have to be these new places of detention. It's just going to be smaller, right? So that's the first step, is if the transfer of power is to community-based organizations, then JPD ensuring that continuity still exists, but we might still have a role, so that's unknown. And you're right, the majority of the focus is around expanding community alternatives. I am hopeful that this, what are they calling it, this wellness hub can be a comprehensive center. They're really trying to integrate holistic thinking and planning based on the proposal to really wrap around services to support youth in a holistic way, and have someone that's going to act as a system navigator to help navigate families, and that's sort of that case management function. And it would be really important for this diversion hub to be in close communication with these new, what are they calling, centers of new places of detention, to really streamline the fewer youth that are detained and come back into the community, to make sure there's seamless integration. And you're absolutely right. We do have significant capacity issues right now within specialty mental health services, and the COVID-19 pandemic has exacerbated that. There's a lot of folks that have retired early. There's a lot of folks that are on FMLA with, personal family struggles. We've had deployments impact us. There's significant vacancies in our contracted providers and pay inequities that make it hard to recruit. And that results in reduced capacity at a time where there are significant needs, an increase in acuity for youth. But we are really hoping that a lot of these investments between the FSPS, the federal, the Federal First Prevention Services Act, that's bringing more funds in place, and other efforts that the mayor and folks have to invest in community can help support that.
Okay, thank you. But I just, I fully support what you're doing. And again, my biggest concern is diluting the essential DPH services for the youth, because that really, to me, would be rather catastrophic for the kids. So
We agree.
Yeah, absolutely. Thank you.
Any other, Commissioner Chow?
Yes, no, thank you. And I really appreciated also the discussion. And I did find the chart, which is on page 66. It's very colorful. And as you explained it, it made sense. But I did have two questions. One was more technical. When you're talking about pre and post in the non-institutional, are we talking about two different systems, or we're going to mix them so that the youth who were pre and the youth who are post kind of live together?
That's already happening a little bit. So like pre-adjudicated youth and post-adjudicated youth are together currently with the secure track that we have and the commitments, which is very radical in some ways and very different than what we've done in the past. So yes, that is what is happening currently. It may shift as some of the programming is developed around the secure track commitments, but currently that is what is happening. Some of the rationale is that there is so very few youth, and so that if we put these 2-3 youth in a unit by themselves, they'd be feeling a little bit more isolated. And so that is what we're currently doing, which is it's very different than what has happened in the past.
No, thank you. The second question was actually following Commissioner Gerardo. How is it anticipated? Because as we start, if we start separating out into units by subject, which is sort of sounding like what this is going to be, who then, if that unit is going to be managing all the medical aspect, which is supposed to be managed by public health? I'm not sure that is really the most effective way to deliver those services. Or is there discussions about how this might be more coordinating center, or it sounds like they really just want to take over everything and hire their own psychologists and their own medical staffing?
I think a lot of that is still unclear, unfortunately. I think we probably share some of the concerns, right, of services being fragmented, youth having kind of multiple different people that they have to connect with. So I think that is something that we definitely want to avoid, but a lot of that, unfortunately, is still unclear around, specifically the medical services and behavioral health services. So
right. I think there was an attempt, or has been attempts, right, like to handle the homeless. And I think that same question came up several years ago, and yet it sort of then ended up as a collaboration, and each of the specialty groups, so to speak, or in this case, public health, managed their own and then worked and coordinated. So perhaps that's a suggestion rather than a new unit going off and hiring their own services. And I'm not sure that also follows under the charter, in which the health of the city is supposed to be under public health. So, I would encourage that if we were able to continue that dialogue to say that it's much more reasonable to be collaborative and working with the expertise that the department has to bring the right people to the table, but it should be coordinated in a fashion in which there's only one point that all the services are going to be reporting to rather than each one and in a silo. And so that would be my hope. But and I think that shares Commissioner Gerardo's concern also. So thank you.
It sounds like if you all need the support of the Health Commission in your efforts, please get back to me and let us know what they can do to help you, because it sounds like there's a lot of negotiations going on with the board and the community. So Commissioner Gerardo, would you like an update on this in any time frame so that we can put this on the calendar and so folks can know? Because it sounds like there's things that are going to be happening in the next year that you may want to hear about. I'm not sure what your thoughts are on that.
Yes, I would like, I mean, you don't have to go through the extensive report. We can keep that, but just an update on what you presented today. And that since there's so much unclear of what's going forward, and that as you heard, and that we are really concerned about coordinated services that DPH provides for youth, being basically watered down in multiple parts of the city, and the kids in tents then on the streets. So if you could come back in maybe the 4 months, 4 or 5 months of whatever, when you have, things are rolling again, and possibly let Mr. Morowitz know, so that again, in whatever we can do, very specifically to support the continuity and standard of care, basically, of services for the youth, and now up to age 25, I guess. I think would be very good for all of us. Not only to further educate us, so we can further advocate for the DPH services. So do you think, I don't know what the timeline is for this work group to get rolling again, but do you know?
We would absolutely be happy to come back and report updates. I think the plan is that the Board of Supervisors are using the Youth and Young Adult Subcommittee that meets once a month to have updates on the juvenile justice reform planning, and they might create a special meeting after hours so youth and families can attend after school. I believe they're going to meet monthly, so I'm not sure what we're going to learn in 4 to 5 months, but we could try to track that and then work with Mr. Morowitz to plan when we have some kind of update to plan a return back.
Great, that would be, and if you also hear through the process that you would need further support from the commission to, let us know basically sooner rather than later.
Thank you.
Okay.
Great. Thank you so much, both of you, for the presentation, the robust presentation, and the discussion. We can now, commissioners, move on to item 5, emerging issues. And folks on the line, if you'd like to make comment on item 5, emerging issues, you can press *3. All right, I hear no comments from commissioners. I see no comments from the community. Item 6 is public comment. So anything that's not on the agenda could be discussed. Any hands? *3, folks on the line? No hands. And so commissioners, you're now out of consideration for adjournment.
I so move
Chairman.
that we adjourn.
Okay.
I second both motions.
I heard lots of motions there. So great. So I'll start with you, Commissioner Chung.
Yes.
Great. Thank you. Commissioner Chow
Yes.
and Commissioner Gerardo.
Yes.
All right. Thank you so much, everyone. The meeting is adjourned. Have a lovely day.
Thank you.